Antenatal care basically refers to the comprehensive care given to a pregnant woman to ensure that she goes through pregnancy, labor, and prepucium safely with the delivery of a healthy baby. The recommended approach to antenatal care is known as focused antenatal care. It has the following principles. It emphasizes quality of care rather than quantity of care, as for comprehensive antenatal visits recommended for women with normal pregnancy. And also individualized care, that means each woman's own medical and psychological needs, and disease detection instead of risk categorization based on the simple principle that all pregnant women are at risk of complications. Pregnant women should be carefully assessed at booking and at all subsequent visits to identify problems that are likely to have adverse effects on pregnancy. Pregnancies with risk conditions as one or more risk factors should be seen more frequently and also referred to a hospital or obstetrician for management. Another important component of antenatal care is the health education and counseling that's given to clients, and these promote healthy behavior and lifestyle during the pregnancy and also enable the woman to recognize danger signs in pregnancy and prepare adequately for emergencies and safe delivery. Findings at each visit should be accurately documented. Antenatal visits scheduled for a normal healthy woman. Women who are healthy at booking and who remain healthy at subsequent visits and do not have any identified potential risk conditions may have 4 comprehensive visits, which are booking visits. The recommended schedule is as soon as a woman suspects she is pregnant, preferably before 14 weeks. The first scheduled visit recommended schedule is at 16 to 20 weeks. The second scheduled visit is in 6th month, about 24 to 28 weeks. The third scheduled visit is in 8th month, 28 to 32 weeks, and fourth scheduled visit is in 9th month, it's about 36 weeks. During the last visit, the woman should be asked to return if she does not give birth within 2 weeks after her expected date of birth. So more frequent visits or follow-up schedules are implemented to meet the client's individual needs. Many clients come for their first visit during their second trimester of pregnancy. In this case, the visit schedule must be modified to ensure that the client receives all the essential components of care before childbirth. Assessment of the mother at the booking visit. So you take detailed history and present health, past medical and surgical history, past obstetric history, family history, and social history. So confirm the last menstrual period and establish gestational age. Examine from head to toe and all body systems, including a check for anemia, blood pressure, pulse, general health status, and manage appropriately. To conduct obstetric examination to confirm pregnancy and measure uterine size and assess fetal well-being. Requests for or conduct screening tests as per national protocol. So assessment of mother at follow-up visits. So he asks about the mother's health status since last visit and asks about health concerns. Inquire about fetal activity, especially gestation more than 20 weeks. Test urine for albumin and sugar. Examine mother for weight gain, anemia, and for complications such as preeclampsia, and manage appropriately. Check blood pressure. The upper limit of the normal is 140 millimeters mercury for the systolic pressure and 90 millimeters mercury for the diastolic pressure. So obstetric examination, you measure uterine size, you measure symphysiofundal height in centimeters between 20 to 36 weeks gestation, and you check the lie, presentation, and position of the baby, and the descent of the presenting part. The third trimester, so you check the fetal heart sounds. Normal rate is 120 beats per minute. Investigations, full blood counts at booking 28 and 36 weeks or more frequently if indicated. So fasting blood glucose must be done on all pregnant women at booking 28 and 32 weeks. Hemoglobin level at booking 28 36 weeks or more frequently if indicated. And like I said, hemoglobin level at booking 28 and 36 weeks or more frequently if indicated. So blood film for malaria parasites, sickling, if necessary, HB electrophoresis, GSPD activity, urine analysis at each visit for proteinuria, glucosuria, stool analysis at booking, blood group and antibody screen, VDRL, TP, HA or RPR test, and HBsAg test as hepatitis B antigen, surface antigen test, HIV antibody testing, counseling required before testing, ultrasound scan, early ultrasound scan for fetal age estimation to exclude ectopic pregnancy, fetal anomaly scanning at 18 to 24 weeks if 24 weeks is very beneficial. So late screening at 36 weeks, placenta position, fetal well-being too. The screening test for diabetes in pregnancy. The fasting blood glucose test must be done in all pregnant women at booking and also at 28 to 32 weeks. And we test for urine glucose at each antenatal visit. Urine glucose of +1 or +2 on 2 occasions, or +3 or +4 on 1 occasion warrants a full oral glucose tolerance test, as OGTT. So those found to have a normal curve can be tested again later in pregnancy, as after 28 to 32 weeks, and those with impaired glucose tolerance or frankly diabetic curves should have treatment. The main treatment objectives are to ensure good health throughout pregnancy, labor, delivery, also the prepurum, to detect and also treat adequately any existing or potential health problems, to prevent anemia and malaria, to ensure delivery of a healthy baby. Non-pharmacological treatment, you encourage the use of insecticide treated nets, counseling and education on the following topics like healthy balanced diet, avoid smoking and alcohol intake, avoid non-prescribed medications and herbs, pregnancy discomforts and management, malaria prevention, family planning, breastfeeding and newborn care, immunization, danger signs and symptoms in pregnancy, exercise, mild to moderate exercise, preferably non-weight bearing, at least 3 times per week is to be encouraged. Avoid exercise in the supine position after the first trimester, and discontinue exercise when there is danger signs such as any of the following, like bloody vaginal discharge, persistent headaches or visual disturbances, faintness or dizziness, chest pain, and unexplained abdominal pain. The exercise is contraindicated in pregnancy-induced hypertension, preterm rupture of membranes, preterm labor, in women with incompetent cervix, second or third trimester bleeding, unexplained intrauterine growth retardation. So develop a birth preparedness and complication readiness plan with the woman. Pharmacological treatment, anemia prevention, first line treatment, you give ferrous sulfate, dried or anhydrous, oral 200 milligrams, 65 milligrams, elemental iron daily, or ferrous fumarate, oral 200 milligrams, 65 elemental iron daily, or iron 3 hydroxide polymaltose complex oral 100 milligrams elemental iron daily. And also you add folic acid oral 5 milligrams once daily, where combination prenatal drug formulations of iron, folate, and other micronutrients are preferred. Ensure that the iron content meets the minimum requirement dose of 65 milligrams per day. Malaria prophylaxis, you give appropriately, usually sulfamethoxazole, pyrimethamine, and oral. You give 5 doses 1 month apart, starting from week 16 or first quickening. Prophylactic treatment should not exceed week 36. For tetanus prophylaxis, you give tetanol IM 0.5 milliliters, the first dose from 20th week gestation, second dose 1 month after initial dose, and if patient has not previously had anti-tetanus immunization. A course of tetanus toxoid vaccinations should be given to all women according to the following schedule. OTT1, you give the first dose 0.5 milliliters SCOIM at any contact with a pregnant woman, including the first antenatal visit. And TT2, you give the second dose at least 4 weeks after TT1. And TT3, you give the third dose at least 6 months after TT2 or during subsequent pregnancy. TT4 and TT5, 1 dose in each of 2 subsequent pregnancies to make up a total of 5 doses. No further doses will be necessary in subsequent pregnancies. High risk pregnancies include bleeding at any time in the pregnancy before labor, young, less than 18 years or older, above 35 years, as mothers in their first pregnancy, presence of medical conditions such as severe anemia, sickle cell disease, hypertension, diabetes mellitus, heart disease, asthma, chronic cough, such as pulmonary tuberculosis and thyrotoxicosis, and also HIV positivity. Women with more than 5 children, as grand multiparous mother, past history of bleeding after delivery or retained placenta, abnormal presentation and position of the baby in the womb at term, transverse lie or breech presentation. So multiple pregnancies, prolonged pregnancy, when the pregnancy lasts longer than 42 weeks, contracted pelvis, pelvis too small for the baby to be delivered safely per vaginum. This may be obvious when the mother is short, as less than 154 centimeters, or has small feet, shoe size less than 4.5 UK. And big baby at term, when the symphysis fundal height is more than 39 to 40 centimeters at term, or when the estimated fetal weight is 4 kilograms or higher. So past history of stillbirths or babies who die within the first week of life, especially if they die in the same problem, The past pregnancy history of miscarriages around the same gestational age, decrease in growth of the baby, fetal growth restriction, uterine size smaller than the gestational age, also uterine size much bigger than the gestational age with one fetus present, previous instrumental delivery, vacuum extraction of forceps delivery, and previous operation on the womb such as cesarean section, myomectomy, or with the uterus, or when the uterus is repaired after um, perforation during DNC, and preterm labor before 37 completed weeks, rhesus negative mothers with rhesus positive husbands or with other antibodies, and women who are at risk of for sensitization must be given anti-D immunoglobulin. It's 500 IU at 28 weeks and repeated within 72 hours of delivery. The referral criteria: high risk pregnancies should be referred to a hospital or obstetrician for management and delivery.